Thank you very much for your invitation and giving me this opportunity to discuss the advancement of supraglottic jet oxygenation and ventilation, SJOV. This is my financial disclosure. First, let us review the major invention that promote the advancement of difficult airway management in the last 100 years. The Miller laryngoscope was invented by Robert Arden Miller in 1941 from USA. The Macintosh laryngoscope was invented by Robert R. Macintosh from UK in 1943. The flexible bronchoscopy was invented by Shigeto Akita in 1966 from Japan. The laryngeal mask airway, or LMA, was invented by Achi Brain from UK in 1981. The combi tube was invented by Michael Fritz from Austria in 1986. The video laryngoscope was invented by John A. Pitzer from Canada in 2009. Now let's introduce a little bit about the institute I'm working in at this time, the University of Pennsylvania. UPenn was established in 1940 by Benjamin Franklin. The head photo on $100 bill. It is America's first university, first medical school, first hospital, first teaching hospital, first business school, and the first computer invention in the world, and had 29 Nobel Prize winners now. In 2023, last year, the Kathleen Carrico and the Joel Weissman from UPenn was honored the Nobel Prize winner for medicine because of the invention of mRNA vaccine for COVID-19. And this is the hospital for University of Pennsylvania new building. It is the biggest building right now, or hospital in the US. And this is the Children's Hospital of Philadelphia. It is always ranked very top, number 1, number 2, Children's Hospital in USA. First, let's discuss about invention of jet nasal tube to promote SJOV. The idea was inspired by the death of Michael Jackson, who died of propofol sedation in June 25th, 2009. At that time, and I'm thinking that one of the major reasons for Michael Jackson's death is hypoxemia after using IV propofol. And recently, especially in the last 5 years, since 2016, that the deaths from fentanyl abuse was dramatically increased. And you can see at 2022, the 73 Sorens people died from this fentanyl overdose. And we all know that fentanyl was significantly suppressed depression, respiratory effect, and that will cause hypoxemia. This to be one of the major causes of the patient death. So when I first started working as a attending anesthesiologist in UPenn, and I frequently encountered this morbid obese patient require the anesthesia, typically monitor anesthesia care or propofol infusion for ERCP or upper GI, and it's really difficult to maintain the oxygen saturation. So I use SJOV technique to maintain it. You can see this is the manual defibrillator, it's a suction catheter, and this goes through the nasal tube. And this is also used in cardiac catheterization lab. This is what I use, the assembly of the jet nasal tube for SJOV. And this is the left side is the first generation of jet nasal tube, and the right side is the assembly what I have used to in the patient. And this is second generation of jet nasal tube, and it's commercially available and internationally. So the first part, I will introduce the publication of clinical study investigating prevention or treatment of hypoxemia during upper GI endoscopy and the proper sedation or monitor anesthesia care. So in the out of OR cases, there is a summary of the closed case lawsuit case due to patient permanent body damage or death, and the monitor anesthesia care or general anesthesia. So among them, 68% are under monitor anesthesia care. And upper GI lawsuit case is 50% of all out of operating room cases. Number one. The 30% of all out of OR lawsuit case was caused by hypoxemia. So I can show you a real case that how SJOV treat hypoxemia. So after propofol, the patient sleep, but the O2 said drop to 84%. Then I need SJOV in addition to the nasal prompt for oxygenation to increase the O2 set to more than 94%. So this is the SJOV, the situation, and you can see the jet pulse above vocal cord, jet into the vocal cord area that prevent hypoxemia and also likely prevent or treat hypoventilation. And this is all the summary of the clinical study in the using SJOV in the GI endoscopy cases and propofol monitor anesthesia care. This is the internationally from different country. One of the major study is the multiple clinical center randomized trial. You can say that the SJOV in upper GI endoscopy and the propofol infusion decreased hypoxemia rate from 89.3% to 2.73%. And a major side effect is dry mouth and sore throat, and there's no complication of bad trauma. And in the Tibet, the place where has a severe hypoxemia baseline in the high altitude, and the SJOV in the upper GI endoscopy can decrease severe hypoxemia from 25% and the nasal cannula oxygenation to SJOV. And also in the ERCP, that SJOV significantly decreased the hypoxemia, like from 21% in the nasal cannula oxygenation to SJOV as 4%. And this the most common side effect is dry mouth, from 2% and the nasal cannula oxygenation to 20% in the SJOV cases. In a morbid obese case, patient under hysteroscopy with propofol infusion, the hypoxemia with O2 stat below 95% has 33% of patients. And in the patient with nasal cannula oxygenation, then this is the decrease significantly to 6% when the patient use SJOV to give oxygen. So currently, I typically put this nasal jet tube and into the hole on the bi-block for the upper GI endoscopy and connect to the jet ventilator, and the other one connect to the CO2 monitoring. And I'll just give a continuous high frequency SJOV at 150 per minute and driving pressure from 10 to 20. And this will significantly prevent hypoxemia. I basically used in all cases to prevent and rather than treat hypoxemia. So in this monitoring, you can see that before SJOV, the CO2 is regular, and after SJOV, you can see the SJOV waveform was superimposed with the patient's own and the CO2 waveform. So compared to high flow nasal cannula, SJOV at high frequency also is high flow. It not only prevent hypoxemia, but also inhibit or treat hypoventilation, while a high flow nasal cannula in the patient of apnea, like paralyzed, they cannot do it. They will have persistently increased hypoventilation or CO2 go up. And the SJOV also effective when the mouth open and closed, while high flow nasal cannula does not. And SJOV can open the airway obstruction, while high flow nasal cannula cannot. While compared with nasal mask, SJOV also can be effective when mouth is open, or also it will relieve airway obstruction, while nasal mask cannot be. So next, we'll talk about SJOV to prevent or treat hypoxemia via bronchoscopy and the propofol sedation or monitor anesthesia care. This is a study using jet nasal tube, main lumen for fiber optic, and also give the jet and CO2 monitoring during bronchoscopy and propofol monitor anesthesia care. You can see that SJOV compared to nasal cannula decrease the severe hypoxemia rate from 9.6% to 2.2%, and severe hypoxemia from 3.7% to 0%. And also the major common side effect is dry mouth from 1.5% and the nasal cannula to 13.1% and the SJOV. This study compared the efficiency of SJOV through the jet nasal tube or through a facial mask. And you can see that they both can prevent hypoxemia, but the SJOV has lower PaCO2, means better ventilation. And this is another study using SJOV in bronchoscopy. Then they show that the hypoxemia, the rate from nasal cannula of 86%, that's pretty high, decreased to 9.1% when used in the with the SJOV. So The next, we will talk about SJOV to prevent or treat hypoxemia in elective or urgent emergent difficult airway. So this is the study how to use SJOV in a paralyzed patient with apnea that give effective oxygenation and ventilation. So you measure from ear to nose length, that typically the adequate length, and insert into one of the nose. At that length, you can monitor CO2. When you do jet ventilation, SJOV, or you do the anesthesia machine, mask ventilation, the CO2. And also you observe the chest rising. You can also put this into the mouth and do the SJOV, see the chest rising and see the CO2. And you can also use the mask ventilation through the anesthesia machine. So this is the patient with the mouth open of only one finger width due to the TMG. Then you can see we use the one side of nose with SJOV after patient under propofol infusion and the muscle relaxant paralyzation. We first do SJOV to see the chest rising and the CO2. And then we do the fiber optic intubation through the other nose. And you can take as long time as you need it to do fiber optic intubation without hypoxemia. This is a study using the jet tubing, then combined with the entry for the fiber optic intubation in a difficult airway while using the jet tubing to maintain oxygenation. Typically, we use LMA, but they change its LMA to the jet needle tube. Then that study showed that they significantly prevent hypoxemia during the intubation. The time you need for fiber optic intubation as long as you need. It's very effective. So for the study, for this one, they basically use SJOV for the resection of the vocal cord polyp and the rigid scope. They typically use a small tube, but this one they just use TIVA, paralyzed patient, and SJOV. They have adequate oxygenation without hypoxemia, but they have slightly increased the PaCO2. Now, this is the case I had. It's an emergent case. Patient had a big vocal cord polyp that blocks the airway, and patient had a difficulty in breathing and come emergently for resection of this tumor. So we use SJOV with the jet ventilator and SJOV assembly of the jet tube, and the surgeon, we did the propofol infusion and also muscle relaxant to paralyze the patient, and the surgeon did the rigid scope and a resection of a big tumor smoothly and successfully and quickly. It takes only about 5 minutes. We do have a backup if it's this doesn't work. We may just push the tumor down and put a emergent endotracheal tube intubation. So in the ESC Emergent Airway Management Guideline and published in 2022, the transtracheal jet ventilation is still one of the approach for rescue the patient with cannot intubate, cannot oxygenation ventilate emergent situation. And transtracheal jet ventilation, you can understand that if you never have used it before and you use it in emergent difficult airway management, That would like you jump off an airplane with a parachute when you never have experience of this using parachute before. The other thing is when you have a difficult airway, the upper airway edema will fully block the airway. When you do TTJV, that will like this boy to blow the balloon constantly until the balloon rupture. In the patient, it will be severe pneumothorax and barotrauma. So compared to TTJV, SJV has following advantage. It is non-invasive. It's the pulse above vocal cord. So it's easy teaching and training and it has a low intratracheal pressure or no pressure and easily used in early stage. It has high successful rate based on our study on in the upper GI endoscopy or others studies, and it has the minimum of trauma. Up to now, we have not heard a single one case of a bad trauma using SJOV. Not like a TTJV with a high failure rate of 64%, a high barotrauma rate up to 30% in emergent TTJV cases. So this new guideline also cite two reference on SJOV to rescue a patient in an urgent or emergent difficult airway. This is the first case basically is the one, and I teaching the SJOV technique in patient, how to use it to maintain oxygenation during elective fiber optic intubation and in a paralyzed patient. And this is the assembly used at that time. And this patient is basically a young female with a obvious difficult, extremely difficult airway and a big tumor in the thyroid. And they did IV induction with muscle relaxant and the use of video laryngoscope at grade 3 view. They tried endotracheal tube, but twice, but not successful. And then the tidal volume, they have partial difficulty mask ventilation. Then the senior anesthesiologist tried one more time with light one, but not success. Then O2 said dropped to 50%. And they call for emergent tracheostomy, but it would be difficult because of a big thyroid tumor. And at that time, they started SJOV at O2 says 10% in about 3 minutes, and they increased SO2 from 10% to 85%. Then they maintained SJOV for 45 minutes until muscle relaxant by sister tracheotomy was gone, and they wake up patient without any brain damage. This is the patient morbid obese in difficult airway, and then they started first using video laryngoscope with low dose propofol, but not successful. The O2 said dropped to lower as 75% Then they started SJOV and paralyzed patient. Then they used do the fiber optic intubation and the SJOV in a paralyzed patient. It takes 7 minutes. They successfully intubate. The blood gas after intubation is basically normal. Then I also propose that the SJOV can be used to resuscitate injured soldier or people in war field. Basically, you get a small oxygen tank and a manual jet ventilator and jet needle tube. When a patient in the war field, if the patient injured, if it's just the patient has dual respiration, you can put this in the mouth as long as the patient tolerate and do SJOV. If the patient already had no breathing, you can put this in the nose, maybe more effective to do SJOV to prevent hypoxemia and hypoventilation. Taking advantage of this light, easily carry or moving around, and the high efficiency of prevent hypoxemia in both patient with or without their own breathing. We also had some case studies for using SJOV to prevent treat a hypoxemia patient with respiratory failure. When the COVID started, I recommend SJOV to synchronize with patient O breathing, like I tested in the OR. This is the manual jet ventilator, jet nasal tube. You put it in the mouth. So when you inhale, you push the manual jet ventilator, give one jet pulse that will synchronize with your own breathing. I feel the cold air when I do the jet going to the bottom of my lung. And you can also use the mask together. That will increase FR2, increase the capability for the oxygenation. Now, here's the one case in Shanghai. The patient with COVID-19 in ICU, the O2 is around 90%. They use SJOV combined with baseline the mask, and they show that increase the driving pressure around the 20 and frequency around 60, but it's manually for a short time. In about maybe 2 minutes, the O2 set increased from 90% to 95%, and you can see the video. So the synchronized SJOV is easy setup, easy learning, even by patients. It's effective to promote oxygenation in patients with respiratory failure, minimal barotrauma side effect. It can have a convenient monitoring of patient breathing by anti-CO2. Now, the side effect of SJOV, in the one study, they use the SJOV and use the ultrasound to monitor the gastric volume, but they did not show any increase of gastric distension by the SJOV using nasal tube before or after its use. In a research study that they in the 5313 patient, the upper GI endoscopy about 18% of sore throat, dry mouth, but no barotrauma. And also, when they did the volume monitoring and the ultrasound in 222 patients, and they found that if the driving pressure more than 25 psi, more than at the 25 psi, the gastric volume actually will be increased from 2.8 to 2.82%. The new study they have, had not been published, and the review is look like if you have driving pressure at 25, it's slightly but significantly increase the gastric distension, but they don't have aspiration or any aspiration in that study. So in summary, SJOV prevent or treat hypoxemia effectively and significantly in gastrointestinal endoscopy, bronchoscopy, and hysteroscopy, and monitor anesthesia care, mostly under propofol infusion. SJOV prevent or treat hypoxemia in elective or emergent difficult airway management. SJOV may prevent or treat hypoxemia in patients with respiratory failure. A common side effect is sore throat and dry mouth, but they did not, SJOV had not had any report of severe complications like a barotrauma up to now. Thank you very much, and this is the my email, and you can email me if you have a question. Again, thank you very much.